So hope everybody's doing well, still social distancing, staying at home through this COVID-19 experience. Hopefully we're on the downhill side, so at least President Trump and Governor Asa Hutchinson has a plan in place for businesses to open back up. So hopefully we can resume our daily routines pretty soon. I'm hoping anyway. All right, so lecture 40, this lecture is going to cover some new developments in blood bank. And as you guys start entering the field, some things that you might see be incorporated into clinical practice. So some things to keep an eye out for. All right, so you guys have probably been paying attention to the news. You know that we are currently in a worldwide shortage of blood, and this usually occurs certain times of the year, and we've talked about this before, where we'll have a worldwide shortage of blood. So what are clinicians supposed to do in these critical shortages of blood? What are some alternatives? And so we're going to talk about some synthetic blood that is in clinical trials now. I did some research last night and found out that there is one institution that is using a type of this synthetic blood, so we'll talk about that. It's not widely used yet, and that's just because the FDA hasn't completely provided guidelines for its usage yet. So, and we'll talk about that as well. But a couple things that can cause these shortages of blood, which will lead clinicians to look for alternative solutions. Increased population growth. The population is aging, they're getting older, so they'll have increased healthcare needs. So we're going to need to be able to treat them as that population age. Generation of new infectious diseases. So when we think about donor testing on our units, within the past 5 to 7 years, we've had several that have been added on to routine infectious disease testing, such as West Nile virus, Zika. And so those are concerns when we are transfusing our patients with human products, is the transmission of those infectious disease testing. So using some of these synthetic products that we're going to talk about, one advantage of that is, number one, the risk of alloimmunization is decreased, and number two, the risk of infectious disease is also decreased. And then in natural disasters, which we are essentially in right now with the COVID-19 outbreak, people are scared to go donate. And that puts a stress on our donor pools. So there's not a lot of products out there for patients. The good news is during this COVID-19 experience, a lot of surgeries are being delayed. So a lot of elective surgeries and other surgeries, they're not being performed right now because everybody's concentration is on this COVID-19. So a lot of OR procedures aren't using blood products, only in emergencies, of course. We still need to be able to support those emergencies. All right, so one thing, I've talked about synthetic blood, but we can also think about our platelets. And the huge concern with platelets, because they are kept at room temperature, bacterial contamination. So platelets are the #1 product that's associated with bacterial contamination. So studies have shown that you can actually store platelets at 4 degrees. This does, of course, lower their platelets activeness, but it does, studies have indicated that platelets are still able to respond. So by storing these platelets at 4 degrees, you have better functional competence. It decreases their inflammatory mediators. So oftentimes the recipient will respond to them better. However, because, and we've talked about this, storing at 4 degrees does decrease their activation. So or decrease their life cycle. So they will only survive for a shorter period of time in your recipient. So that's the drawback. That's why most clinical blood banks are still storing their platelets at room temperature. And that's just because those platelets don't survive as long as at 4 degrees as they do at room temperature. So keep that in mind. Research is currently undergoing adding preservation fluid to those platelets to help with their activeness, help with their lifespan. So that might be something that you see if you start working in blood bank. You might see platelets begin to be stored at 4 degrees just to extend their life and prevent the risk for bacterial contamination. And if you guys, I have made some updates to this presentation. So if you guys downloaded it last night or earlier this morning, I've made some changes to the next upcoming slides just to provide some more information about how the synthetic blood really works. I wanted you guys to understand that. All right, and so like we mentioned, due to the critical blood product shortage, clinicians are always looking for ways to substitute the actual red cell. And usually when patients are transfused, the most common one, of course, is red cell products, and that is just to improve the patient's oxygen carrying capabilities. So it's not necessarily that they need the cells, they just need the oxygen. So there are some blood substitutes that have been proven to allow for this oxygen transport. So there have been some different hemoglobin extractions that we're going to talk about, whether that be acellular or cellular, and whether that be transgenic. There's research right now that is using E. coli to develop some of the hemoglobin molecules, and then it is treated, and then it can be used as an oxygen carrier. Perfluorocarbons, we'll talk about, is a synthetic substance that can bind to oxygen, or actually it dissolves oxygen, and then stem cells. All right, so your modified hemoglobin, so the half-life of hemoglobin is actually equal inside and outside of the red blood cell. However, outside of the red cell, and we talked about this, taking it back to hematology, then think about your hemoglobin molecule. It's a tetramer. It's usually composed of 2 alpha chains and 2 non-alpha chains. The most common adult hemoglobin, of course, being hemoglobin A with the 2 alpha chains and the 2 beta chains. So the natural tetramer molecule of hemoglobin rapidly converts. So outside of the cell, that hemoglobin molecule is going to break down very rapidly into those alpha and beta dimers, and then that's your globin chains, and then that heme is what is toxic. That, remember, in heme is composed of that protoporphyrin ring. So outside of the cell, that does break down very rapidly. Therefore, hemoglobin outside of the cell is not very adequate at carrying oxygen. Therefore, we can modify that hemoglobin molecule to improve its oxygen carrying capabilities. So we can modify that hemoglobin molecule, use it to transfuse into the patient to carry that oxygen carrying capabilities. Another thing is hemoglobin outside of the cell, it separates from 2,3-DPG. And if you guys remember also from hematology, T3-DPG must be incorporated into that hemoglobin molecule to allow for release of oxygen. So if that hemoglobin molecule loses the 2,3-DPG, which acts as a bridge in between those chains, then the infinity for oxygen is increased, meaning that the hemoglobin molecule doesn't want to release it. All right, so we need that 2,3-DPG to be released, or to be incorporated into the cell for release of oxygen. All right, so there's really two methods that we can modify this hemoglobin molecule. And it can be acellular, meaning that it's modified outside of the cell and transfused as a polymer into the patient, or it can be cellular. And so we're primarily going to talk about the acellular techniques in the next few slides. All right, so how this works is acellular hemoglobin. Hemoglobin can be extracted from human red cells, or there are even some manufacturers that are in providing products in clinical trials right now that are using bovine, using cow cells. So they're extracting the hemoglobin from cows. So what is happening is they're extracting the hemoglobin, so they're alpha and non-alpha chains, and they're cross-linking them to prevent the hemoglobin tetras from breaking down. And this means that those dimers do not break down, that they stay in circulation for shorter times. And what happens is when these dimers break down, they can be excreted from the kidneys, and then they can cause kidney damage as well. All right, so there's 3 types of acellular modified hemoglobin. And on the far left here, you have your cross-linked hemoglobin. So usually your tetramers of the globin chains are covalently bonded together. They're cross-linked here. And it's usually in between the alpha chains, right? So they're all bonded together just to help prevent detachment, right? So that keeps the hemoglobin molecule in place by cross-linking. There's also polymerized hemoglobin, and that's just where the hemoglobin molecules are cross-linked together to increase the molecular size. And it's usually composed of 4 to 5 molecules. There are certain chemicals that they use to polymerize those hemoglobin molecules. One of them would be a glutaraldehyde used to polymerize it. And then there's conjugated hemoglobin, which inert polymers are attached to the surface of the hemoglobin molecule. The conjugated hemoglobin is the one that has proven to be most successful in the clinical trials that are currently going on. And the reason for all of these, whether it be cross-linked, polymerized, or conjugated, is just to make these hemoglobin molecules more sustainable. So they're improved oxygen carrying capabilities, and they survive in the patient longer. So I took this, there's a research article that you can find on PubMed, and I provided the link here if you guys want to read about it. It's very interesting. These are the most common synthetic modified hemoglobin products that are currently in clinical trials or being used. And you can see there's one, it's called diaspirin. It is a cross-linked type of hemoglobin. It's derived from human red cells. And it is in phase 3 of clinical trials. So we're not seeing it in clinical practice yet. It still is in clinical trials. However, there is one, it's called HemaPure, and it is actually being used by the University of Florida. They have it, it's documented on their website that they are currently using it for their OR patients. In place of blood products. And so it is derived from bovine, and it uses that glutaraldehyde reagent that I talked about. A problem with all of these that you will notice that is listed here is it has a problem converting ferric iron to ferrous iron. So if you remember from hematology, we need iron to be in the ferrous state. That is when it will bind to the oxygen. All right, so sometimes these synthetic hemoglobin molecules are unable to convert ferric to ferrous. That's another disadvantage of all of these, and that's another reason why the FDA hasn't approved very many of these synthetic hemoglobins. So here's your conjugated hemoglobin that I mentioned down here at the bottom. The Hemospan and the M4, those again have been proven to be the most efficient. However, there are side effects. Some side effects have been proven to cause hypertension, renal failure, cardiac arrest, I believe, on some of these products. So that's another reason the FDA hasn't provided approval or guidance for using these products. But the reason we include this in this lecture is as you guys start working, some of these might get FDA clearance, and you might see some of these products being used instead of our regular donor products. And so like we mentioned, HemaPure is the brand name. It's completed phase 3 clinical trials. It is being used by the University of Florida, like I mentioned, but it is still waiting for FDA approval. And then polyheme, which is one of your polymerized synthetic hemoglobins, it is also waiting for FDA approval. So some advantages of using modified hemoglobin, again, no red cells are involved, so we're just transfusing the hemoglobin molecule, so we do not have to worry about our recipients being exposed to foreign antigens, therefore being alloimmunized, therefore building the corresponding antibodies. You don't have to worry about cross-matching. These are universal compatible, so there's no ABO antigens to worry about. No cross-matching. They can be given across all the different types of ABOs. And they can be lyophilized and stored as a stable dry powder, so they have a very long shelf life versus our products that we normally keep in our inventory. We have to worry about expiration dates. With these, they have a longer expiration dates. One thing, an article I did read mentioned that these products have been shown success in those patients that are emergency, whether that be a trauma or a surgical use, because of it's a temporary solution. So it might not be the perfect alternative for like a sickle cell patient. It's a rapid and short-lived therapy. So it has been shown to be more efficient in trauma and surgical use. So you might see it on the surgical side of blood bank. All right, so there's another type of modified hemoglobin, and it's called encapsulated, or what's the other word I had? Recombinant hemoglobin would be here, as well as hold on, I had the word. Transgenic. So using other species to obtain the hemoglobin and then using it for human use. So encapsulated, recombinant, transgenic. And it's encapsulated, it acts more like artificial red cells. A disadvantage to using these is that it is quickly removed by the reticuloendothelial system. So you'll also see a very short half-life with these recombinant hemoglobin as well. So currently, research is actually being done on a bacteria, E. coli, is shown to be able to grow the human alpha and beta hemoglobin dimers. They can be extracted, modified, inactivated, and then given to the patient for oxygen carrying capabilities. So that's what makes it recombinant, encapsulated, and transgenic. There's all different types of E. coli, and if you do some research on this, you'll see a downside of this recombinant hemoglobin. Number one is it shorts half-life, and number two, it has a receptor site that blocks nitric oxide, and nitric oxide plays a huge role in vasoconstriction. So if nitric oxide is blocked, then the vasoconstriction does not occur. So there are several studies that are undergoing modifying the hemoglobin molecule extracted from E. coli and varying some of the receptor sites to try to prevent that vasoconstriction. So that's some current studies also going on. All right, so then we have some chemical oxygen carrying capabilities that are given to patients. Perfluorocarbons, and some of you guys might have heard of these. This is a synthetic organic material. It's capable of carrying oxygen. There is one that is currently being used in the OR, and it's called Fluosol DA, or a common name, Oxygent. The thing about these perfluorocarbons is your patient must be receiving oxygen therapy. So they would have the nasal cannula delivering oxygen. And that is only because these perfluorocarbons will bind to those oxygen molecules and dissolve that oxygen. And so that's how it is carried throughout the body. It's thought that these perfluorocarbons can reduce homologous blood by 2 units when it's used in conjunction with some autologous options such as cell saver. It's also thought that perfluorocarbons can increase oxygen tension after a patient experiences a thrombosis or a stroke. And then also we've talked about those Jehovah's Witness patients that refuse to receive blood products from another being. So perfluorocarbons might be a good alternative for those patients to improve their oxygen carrying capabilities. An advantage of these perfluorocarbons, it can be produced in large quantities. It is not human derived, so there's no human products. Again, it is synthetically derived. Some disadvantages: the patient must be on oxygen in order for the perfluorocarbons to work, but the reticuloendothelial system is going to rapidly destroy these perfluorocarbons. And it can be kept frozen until use. So there's another brand of the perfluorocarbon. It's called Oxygent. It has recently been rejected during clinical trials because of the side effects, some of them including increased risk of stroke after administration. It has been shown these perfluorocarbons to cause the patient's platelet count to decrease. Now, the association of the decreased platelet count to perfluorocarbons, I do not know what that association is, but several clinical trials have been stopped because of the association of a decreased platelet count. And then the patient might even exhibit some flu-like symptoms as well. So there's also some research out there that studies if a patient is given perfluorocarbons in combination with blood product component therapy, there have been no known side effects, no interactions between the two therapy options. So it might be where a patient receives both. So there's another option, and that is utilization of stem cells for hemoglobin. Those stem cells could stimulate the production of hemoglobin, and then the cytokines released from those stem cells could also increase the hemoglobin production. This is not widely used. More commonly, stem cells are used for more hematological conditions, such as, of course, bone marrow malignancies such as leukemia or sickle cell or thalassemia. But research is undergoing stem cells for the production of hemoglobin. We'll come back we'll talk about umbilical cord blood, extracting the stem cells from the cord blood in just a little bit. So we talked about artificial hemoglobin being used for an alternative to blood products. There's also the creation of artificial platelets, also currently in research. One is Cyplex, and they're infusible platelet membranes. They have a much more longer shelf life than donor cells. And the way these Cyplex products are derived is they take expired donor platelet units and they treat them. They'll go through a series of centrifugation, washing, and then what's left is you have the platelet membrane of those platelets that were originally in the donor unit and have broken down due to their expiration time and their lifespan. So then you have those platelet membranes. It is thought that those platelet membranes still have the glycoprotein 1B receptor site on it, which can bind to collagen in the event of a damaged vessel. So then that could initiate the coagulation cascade and stop your patient bleeding. So that is the principle behind these artificial platelets. They are not full platelets. They only contain the platelet membrane with the receptor sites for activating and responding to a damaged vessel. They're non-immunogenic, all right? So we don't have to worry about platelet antibodies that we would normally with platelets. And this is a really good option as well, since we don't have to worry about those platelet antibodies if your patient has become refractory to those platelet transfusions, meaning that they have received multiple units of platelets and their platelet count is not increasing as it should. Then the Cyplex might be a good alternative. Again, because the antibodies wouldn't be involved and they would still have the capability to form a clot and stop the bleeding. This is not widely used yet. In my blood bank experience, I've never heard of this being incorporated into the clinical atmosphere yet. So there are still several studies and clinical trials right now. And we've talked about these synthetic volume expanders as well, used for patients that are in shock. It doesn't require oxygen carrying capabilities, but it just requires, it improves their volume. So we talked about some crystalloid solutions, saline and ringers, and then some colloid solutions such as dextrin. So some other ways that could be alternative methods for transfusion is to reduce iatrogenic loss. Most patients from having repeated labs drawn, they could experience some blood loss through that. So one way to avoid that is to draw less from patients for lab tests. And we're starting to see that being incorporated with some of our testing technologies requiring decreased amount of blood for each test. So that has helped as well as minimizing blood loss during surgery through some of the procedures that we've talked about, cell saver, hemodilution, all of those options have helped as well. And then also maybe rather than giving your patient a transfusion, maybe treating with erythropoietin to stimulate the production of red cells to increase their oxygen carrying capabilities. That is a much safer alternative than transfusing with donor products or using any of these synthetic products with the known side effects. There are some mechanisms in place to minimize the blood loss, which would minimize the need for blood products as well. And this occurs during surgery. And one of them is aproteinin. And what this is, it's a trypsin inhibitor. So it inhibits the kallikrein and your plasmin. So think back to your coagulation cascade. It is going to help prevent the start of the coagulation cascade and then inhibits plasmin as well. So while the coagulation cascade will start, the fibrinolysis is inhibited. So the patient will continue to clot and prevent that bleeding. So that's one example, aproteinin. There's another example, fibrin glue, to prevent excess bleeding, and one example of that is through topical thrombin. Just be aware, you do not want to use this if your patient is in surgery and they are using cell saver. Okay, that fibrin glue, of course, will cause the patient's blood to clot. and then we don't want our blood to clot and then give it back to the patient. That could cause them to have an aneurysm. So just be aware, if you're ever involved in the cell saver process, don't let them use any type of fibrin glue. And then hemodilution that I mentioned earlier, that's just where the patient prior to the surgery, they'll have some blood removed and they'll replace that volume with saline. It prevents the amount of blood loss during the surgery, and then after the procedure, that blood is given back to the patient. That all occurs in the OR. Typically, blood bank is not involved in that process. That unit is collected, stored, and then given directly back to the patient. Again, that decreases the amount of donor blood that the patient might be exposed to, or the need for any of those synthetic products that we talked about. And then another option, hypotensive anesthesia. So certain drugs can be given to the patients that are vasodilators that will lower the blood pressure during the surgery, reducing the amount of blood loss during the surgery. It can reduce that blood loss by up to 50%. Again, reducing the need for transfusions. Another option maybe is to give your patient oxygen therapy, like we mentioned earlier. Decrease the metabolic rate by lowering your body temperature. So remember, if you think back to your oxygen dissociation curve from hematology, that would be a right shift in the oxygen dissociation occurred, therefore increasing or decreasing the amount of 2,3-BPG, therefore increasing the amount of 2,3-BPG, therefore increasing or decreasing the affinity for oxygen. So the cells will readily release the oxygen to the tissues, so you won't have the event of tissue hypoxia. And then you'll see most all blood banks have done this now, as they have lowered their thresholds for transfusion criteria. So your patients have to meet that certain hemoglobin of 6 grams per deciliter before they can be transfused, or your patient's platelet count must be 20,000 per microliter before they can receive a platelet transfusion. I assume that every clinical blood bank has established those thresholds in order for blood product management and proper transfusion monitoring of their patients as well. So another thing is we can think about our donor collection process. We can try to get the utmost product from our donors. And one way to do that is a double blood donation through apheresis. So a donor could actually donate 2 units. You can usually get about 500 mils of red cells, compared to if you were to do a normal red cell collection, you usually only get about 200 to 250 mils of red cells. So this is kind of a double donation. However, the donor requirements are a little bit different. They have a higher weight restriction, so they must be at least 130 pounds instead of the normal 110 pounds. And with that, so a normal, if you donate red cells, a normal time period before you can donate again is 8 weeks. So if they do a double unit donation, they can donate every 4 months. So it doubles from 8 weeks to 16 weeks. So there's another option as well. You can pathogen and activate some of the products. Again, that's one of the main concerns for patients receiving human-derived products, is the transmission of infectious diseases. So pathogen inactivation is also being researched right now. And again, the concern there is for bacterial contamination of platelets. It's the most common bacterial contaminated product. Another way that we have tried to reduce the transmission of infectious disease, which we talked about during our donor collection process, is incorporation of nucleic acid testing, which has decreased the window time from the time the patient was exposed to the time we can detect it in our testing nucleic acid testing has decreased that window. Therefore, we are better able to identify those patients that might have been exposed, but not yet are exhibiting symptoms and not have been diagnosed. And so we're able to decrease the amount of time that it takes to detect that. So some examples of pathogen inactivation, psoralen is used to bind to the DNA and it prevents the unzipping. So what it really does is it prevents the bacterial and viral replication. It does not affect the function of the red cells, plasma, or platelets because they do not contain a nucleus, of course. The procedure is expensive. It does expose the entire unit to chemical contamination. It does use a form of radiation. So the concern with this, is it worth exposing the unit to radiation and then exposing that radiation that unit being exposed to radiation and then given to our recipients. So this is not a widely used mechanism either, not yet. So we talked a little bit about stem cells earlier. There is the process, and you guys are probably well aware of this, that cord bloods are being used for stem cells as well now. And like I mentioned earlier, really using that to treat bone marrow malignancies such as leukemias, any type of congenital hematological disorders, and hemoglobinopathies such as our sickle cell, thalassemia, and congenital immunodeficiencies. And so this diagram here really explains how the umbilical cord processing for stem cells occurs. So you have your cord blood that's taken during the birth. That cord blood is going to be treated with a solution. It's called prepacite. And it is going to bind to all of your nucleated cells and CD34 stem cells. And then you spin it down, and then you have your stem cells remaining, and that can be extracted from the cord blood. UAMS is actually collecting cord bloods. You can, if you are a pregnant female during delivery, you can donate your cord blood for research. You can also store your cord blood for in the event that you have a future genetic diagnosis, such as leukemia. You will have that cord blood that can be used for treatment options. However, storing that cord blood is very costly. It is very expensive. They usually charge you a yearly fee. And so the likelihood that you will need it is very low for that high cost. So that's something you really have to think about. Some advantages of using that umbilical cord, it is easily collected, so no additional harm to the mom or the baby. Versus if you think about having to collect the stem cells from a peripheral collection, most oftentimes colony stimulating factors are given, again, to stimulate the release from the bone marrow of those stem cells. Stem cells from cord bloods are less mature, so the likelihood of graft versus host disease is also decreased by using stem cells from the cord blood. And then there's the concern of HLA matched siblings. So a lot of ethnic minorities who don't have any siblings, finding their HLA matched can be very difficult. And they are not well represented in the National Bone Marrow Donor Registry, again, because they're minorities, such as your Southeast Asians and all of them. They're not well represented in the Bone Marrow Donor Registry. So using cord blood stem cells, because they're less mature, less immunologic, then the requirement for those HLA matched is not as severe. So cord bloods might be an alternative for those difficult HLA matched patients. Some disadvantages for the umbilical cord cells. Sometimes our yield is not considered a therapeutic dose. Sometimes you only really get enough for a therapeutic dose for children and adolescents. That's oftentimes why a lot of people choose to store. their cord blood for future use in the event that a child is diagnosed maybe with acute lymphocytic leukemia. Then they have those stem cells that could be used for treatment. And like I mentioned earlier, UAMS does have a cord blood bank. They do store umbilical cord blood for the state of Arkansas. And if you guys are interested and ever get to opportunity where you are having kids, UAMS does take the cord blood for research, so you can donate it. We talked about storage. Again, it is very expensive. And then chances, again, do you pay that outrageous fee for storage for the chances that you will need a stem cell is very low. There's actually another alternative that for platelets that I wanted to mention real quick. It's not included in the presentations, and you guys don't have to know it, but as you start working in blood banks, you might come across it. Arkansas Blood Bank, or Arkansas Blood Institute, is actually doing this right now, and it is a commercially manufactured testing kit, and it's called Verax. And what it does is it tests each platelet unit for bacterial contamination. And a normal expiration date for a platelet unit is 5 days. So research has shown that if your platelet count and your bacterial contamination is low, okay, so if your platelet count is still good and your bacterial risk is low, then you can extend the expiration time of that platelet 24 hours more past the original expiration date. And so let's say if you had a platelet unit that was set to expire today, you did a platelet count on that unit and it was still within the threshold, and then you did your Verax testing where the bacterial colony count was 0 to minimal, then you could extend that platelet expiration date 24 more hours. So it's a way to still allow for the uses of platelets. It reduces the wastage of those platelet units, so they can still be transfused into your patients. So that's something to keep in mind. Again, it's called Verax. All right, so in this lecture, we talked about some alternatives to transfusions. We talked about some synthetic blood, and I think synthetic blood has really been commercialized maybe in movies and shows. It's not really blood. It's more of just the hemoglobin molecule that is really being modified right now. So we talked about several different companies that are working on modified hemoglobin options. There are several in clinical trials. So you guys keep a watch on that, see if FDA approves any of those for transfusions. It could change the product inventory in blood bank if they ever do get approved. We talked about modified and encapsulated hemoglobin. All right, so it's that hemoglobin that has the oxygen carrying capabilities. We talked about the perfluorocarbons that can bind to that oxygen and deliver to the tissues. One thing about the perfluorocarbons as well is it has really been shown to be effective in those patients that have thrombotic events. All right, so it's able to carry oxygen to the microvascular areas. So this chemical can get into very small areas, maybe where a hemoglobin molecule is unable to get into. So that's an advantage to the perfluorocarbon as well. We talked about some artificial platelets. Again, those are the platelet membrane remnants with the receptor site that can bind to collagen when a damage to the vessel occurs, which will initiate the coagulation cascade and help stop the bleeding. And then we talked about cord blood and stem cells as some alternative means to transfusing products. And so really the main concern here is the need for these synthetic products. It all boils down to the safety of our donor products and the availability of our normal blood products. Again, transmitting infectious diseases, being exposed to foreign antigens, those are the main concerns using human-derived products. And so with these synthetic products, they all have their own side effects, like we mentioned, hypertension, cardiac arrest, kidney failure. So that is why they have not been approved by the FDA as of yet. All right, so that is lecture 40. Does anybody have any questions? Well, if you guys are doing research and come across any other new blood bank topics, please let me know. It was actually Arkansas Blood Institute that shared with me the VARX, that the new testing that they have recently incorporated. So if you guys come across anything new, please feel free to share.